Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me. I wish to extend special thank you to my supervisor and mentor, Brigadier Professor Azmat Hayat, and also to Professor Akhtar Ali Bandisha for his wonderful vision in helping to arrange this amazing event. I know that the audience is varied. We have some of the most experienced professors in the country, but we also have some very inexperienced doctors, maybe a few house officers, and also some PGTs starting out in their journey of medical training or even cardiology training. So I made this presentation with you guys in mind because I remember what it was like working the first days in my training job and having to deal with tachycardias and wide complex tachycardias and narrow complex tachycardias. So today my presentation is going to give you the tools to navigate the most complex and most difficult scenarios. A patient comes into the emergency room and they have a wide complex tachycardia. And I'm going to give you a mnemonic, a way of dealing with it based on logic, based on an understanding of the physiology and an understanding of ECG. Dr. Colonel Atif Rauf mentioned that I like taking pictures of ECGs. I was taught that by my supervisor, Brigadier Azmat Saab, to take a picture of the ECG and look at the core components of that ECG. And that's what I would advise you to do. Obviously, we have spot diagnosis, which you can do, but obviously you should break down ECGs into their core components if you want to get to the nitty-gritty. So I'll tell you my mnemonic while they're loading up my presentation. So if you have a wide complex ECG, tachycardia, you can be sure, even if you don't have any other further information, if somebody phones you from the emergency room and says, we've got a wide complex tachycardia. If you have no further information, the probability is there's a 70% chance it's a VT. If somebody tells you the patient has a history of ischemic heart disease, heart failure, they're elderly and they have multiple comorbids, that percentage goes up to around about 90%. So 90% certain if the patient is elderly, has ischemic heart disease, has heart failure, you can be 90% certain that their wide complex tachycardia is a VT. And from my training in AFIC, I was always encouraged to give the patient a shock if unsure, or if you think there's a good chance it's a VT, give the patient a shock and see what happens later on in the morning when they've reverted to sinus rhythm. So my mnemonic is the ABCDE approach. As soon as this thing comes up on the slide, I will go through it with you. A stands for axis. Is it a northwest axis or not? B stands for broad complexes. Really, really broad complexes, more than 200 milliseconds, which is 5 small squares. C stands for concordance. We started. Excellent. C stands for concordance. D stands for VA dissociation. And E stands for the early part of the QRS. So we're going to go through that mnemonic, and also we're going to have 5 questions for you guys to go through. So as I mentioned, any of these ABCDEs, if you have even one of them, it's highly specific, not sensitive, specific for VT. So there's very little chance of it being a false negative. So A for axis. Now, I hope you all know how to calculate the cardiac axis. Officially, you look at lead 1 and you look at lead AVF. But also, if you're looking for a shortcut, you can look at lead 1 and lead 2 as well. If both lead 1 and lead AVF are predominantly negative, it's a northwest axis, an extreme right axis deviation. Alternatively, you can look at lead AVR. Now, in a normal person, normal ECG, normal sinus rhythm, AVR is typically, the QRS is typically negative. But what happens if you have a wide complex tachycardia and you see this? Next. Okay, so you can look at lead 1 and lead 2. The QRS is wide. It's a tachycardia. Both lead 1 and lead 2 are predominantly negative. Looking at lead AVR, you see something unusual. There's a broad R wave in lead AVR. It's a very strongly positive QRS deflection in lead AVR. So that gives you a clue something's wrong. AVR, if you think about the ECG, I think one of the principles of ECG is electrical current. If it comes towards you, it gives a positive deflection. If it moves away from you, it's negative. So where is your lead AVR? AVR is where your right arm is. So if the current is going towards your right arm, it's coming from below and the left. So it may be coming from the left ventricle. ventricular tissue certainly. So that's the principle. So a broad AVR, a broad R wave in AVR, or a prominent extreme right axis deviation, meaning -1, negative AVF, or -2, means that it's very specific for VT in the context of a wide complex tachycardia. So I hope everybody gets that. Let's move on. Okay, broad complexes. Broad complexes. Well, we're going to go into why broad complexes are specific for VT, but if you've got a wide complex tachycardia and it's more than 5 small boxes in width, so don't just eyeball it, take a picture of it. Use your smartphone, take a picture, use the chest leads, look at 2 or 3 chest leads, V1, V2, V3, and really look and see where the QRS begins and where it ends. And if it's more than 5 small squares, it's very broad, and you're very likely to have VT. If we're talking slightly less, sort of 160 milliseconds, 150 milliseconds, then you lose specificity. So if you've got a broad complex tachy, 200 milliseconds or more in width, you can be reasonably sure that it's ventricular tachycardia. Next, concordance. Concordance means that all of the chest leads are predominantly in one direction. They're all either positive or they're all negative. In this scenario, it's 97% specific for VT. So that's quite a strong proof. So I'm going to give you an example. Next, please. So concordance, C for concordance, you can see the ECG on the left-hand side of the screen. They're all positive, right? And another thing is they're all quite sort of slurry. It's sort of a slurred upstroke. That's another sort of indicator. But what we're looking at here is they're all positive, and on the right side of the screen, they're all negative. So this is another indicator that's specific. So we've done A, which is axis, B, broad complexes, C for concordance. I hope everybody understands this. Next. Okay, this is slightly difficult. Now, we know that these are present in around about 55 to 60% of VT ECGs. However, the diagnosis power of most doctors is around, they can see them in about 10 to 15%. So they are prevalent. You see them in ECGs if you really look at it. And the technique you use is the same that Dr. Atif was showing you earlier on. He was showing you how there were P waves hidden in T waves, and you need to look for those hidden P waves. In fact, when you look at an ECG, once you've looked at the parameters like rate, rhythm, axis, you've checked paper speed, you've checked voltage box, the first thing you should look for is go in alphabetical order, look for the P waves. See, can you see any P waves? So VA or AV, we prefer to use the terminology VA dissociation because in VT there are more V's than A's. The ventricle is firing, 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 firing. Some of those V's are transmitted through the conduction system to produce a P wave, but sometimes they're not because the AV node might be refractory because it's going so fast. There are other ways of pathognomonically diagnosing VA dissociation. One is a capture beat, so your V is firing, 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 and for some reason, just by chance, a sinus beat fires from the sinus node, captures the AV node, and that captures the ventricle, and you get a normal QRS complex. That is pathognomonic for VT. I will show you an example. Fusion beat, where you've got one sinus beat firing, and you've got one beat coming from the ventricle, and they fire at the same time, and they kind of meet in the middle. They produce a hybrid complex. It's an exact mix of a sinus beat and a ventricular beat. And the way you look at it is you've got a beat which is of intermediate width. And I'll show you an example. Next slide, please. So here you've got a wide complex tachycardia. The first beat, the second beat are wide complex tachycardia beats. Then you've got a beat which is kind of not as wide or as big as the tachycardia beats. Going on further, 4 or 5 beats later on, you've got 2 beats that look like sinus beats, and those are capture beats. One of the sinus node depolarizations has managed to get through the AV node into the bundle branches and has captured and depolarized the ventricles. And that is, you can see that they have a large Q wave, significant Q waves, more than 25% of QRS size. That suggests that maybe there's a myocardial infarction. We won't get into that. But you've got capture beats there, and you've got this intermediate beat, which is a fusion beat. And the fusion beat happens on time. It happens at the same rate as the VT beat. So I hope you can see the three different types of beats. You've got VT beat 1, the second beat is a VT beat, then you've got a fusion beat, then you've got around about 6 VT beats, and then you've got 2 what look like normal sinus beats, capture beats, and then there's a sequence of 3 VT beats. So if you see that, that's pathognomonic of VT, it's evidence of VA dissociation. In addition, going back to what Colonel Latif said, if you see P waves intermittently, but they're not constantly present in all of the beats, that's also evidence of VA dissociation. Next slide, please. Now, this is an important concept. VT is a ventricular, if you're talking about the most common type of VT, which is myocardial VT. Our patients, they have myocardial infarction, they have a scar in their myocardium, and that produces a circuit, a re-entry circuit, or even multiple re-entry circuits in the ventricular myocardium. So basically the origin of the rhythm, as opposed to a normal beat originates in the sinoatrial node, but a VT originates in the ventricular myocardium. A normal beat, as shown by Colonel Latif earlier on, has the luxury, it goes through a super fast conduction system, like a motorway. It goes through the sinus node, the AV node, the bundle of His, the right and left bundle branches, and in the Purkinje system. That's a really, really specialized, fast system. But a VT is originated in the ventricular myocardium. There's no, usually, I mean, there are other types of VT that electrophysiologists know about. We're not going to get into that. But a myocardial VT originates from the site of a scar following a myocardial infarction or a cardiomyopathy. There's no fast, specialized conduction tissue around. So the only way of getting from one place to another is cell-to-cell communication. And cell-to-cell communication means it takes a long time. It's a really slurry initial part of the QRS. If it's a very rapid initial upstroke, it means it's going really fast. It's going through conduction tissue, and that suggests an SVT. But if it's going really, really slowly, the initial part of it, the change in Y over change in X, the rate of change is very slow, then you can be relatively sure it's VT. There's one criteria that we use, and I suggest you use it if you're stuck in an FCPS exam and nothing is making sense, and this lecture doesn't make any sense to you either. One thing you can do is you can look at limb lead 2, and look at the R wave peak time or look at the S wave peak time, and see how long does it take that initial portion of the ECG, of the QRS, to get to its peak. If it takes more than 50 milliseconds, which is a shade over 1 small square, then you can be reasonably sure it's ventricular tachycardia. So that's the ultra simple Brugada criteria. Look it up on Google when you get out of here. Next, please. So this is an example. This is looking at V1 in the top ECG. This is SVT with aberrancy. The initial part, it's a wide complex tachycardia, but the initial part of the QRS is very, very rapid. It's a very fast upstroke. It's almost like a vertical line if you look at it. So you've got almost a vertical line. It's not a slow rising early part of QRS. Looking at this, the second ECG is not from the same patient. The second ECG is taken from a patient who had a history of myocardial infarction and heart failure and presented in a state of extremis. Now, looking at chest lead V2 in this case, it's from the start of the QRS to the top of the QRS. It's taking a while. It's taking a long time. It's taking more than one small square. It's taking a couple of small squares, I believe, or 2.5 small squares. It's certainly more than 40, 50 milliseconds. So a slow rising initial portion of the QRS. Limb lead 2 is a good one, but you can look at the chest leads as well. Gives you a good indicator that the impulse, the depolarization, is traveling slowly. It's traveling slowly because it's going through cell to cell rather than going through specialized conduction tissue. So putting it all together, we discussed at the beginning of this presentation that if it's a broad complex tachycardia, you can be 70% sure in the absence of all other information that it's a VT. If you have other information, like the patient has lots of comorbids, heart failure or ischemic heart disease, without any further information about the ECG, you can be 90% sure. Then we mentioned that if you want to be really, really sure, you need to look at the ECG, obviously. And any of these criteria, A for axis, B for broad complexes, more than 200 milliseconds. C for positive or negative concordance. D for dissociation, which can include either capture beats or fusion beats. E for the early part of the QRS. So go through the algorithm. If you have any one of these features, you can be certain that it's VT. You can be certain that it's VT with a very high degree of specificity. Let's have a few examples. These examples are not necessarily related to, all of them are not necessarily related to what we've done, but they are quite closely related. Next, please. Mini quiz. Just do 5, and then we're done. We'll have some audience participation as well. Next. Okay, so this patient comes in, young, 23-year-old male patient, no previous history of note, presents with severe palpitations, and the patient has a blood pressure of 120 by 80. What's going on? Do we have any idea what's going on? Because ARS, I believe, is not activated for this. So, is it regular or non-regular? So it's irregular. Is it wide complexes? Okay, so it is wide complexes. Can anybody see? Okay, let's go through our algorithm. Is the axis extreme northwest, or is it a normal axis? So it's a normal axis. A is gone. Are they really broad QRS complexes, or are they sort of less than 200? So it's less than 200. Okay, let's go to concordance. Is it positive concordance, pure, or negative concordance? Is it negative concordance? Is there concordance? Because leads V1, V2, V3 are predominantly negative, V4, V5, V6 are predominantly positive. So there's no concordance. And the early part of the QRS, is it really slurry or not slurry, or is it variable? It is variable, actually. It's variable. If you look at the bottom of the screen in the rhythm strip, it's not that broad, but the degree of slurring is variable. So you've got variable rate, variable ventricular rate, an irregularly irregular rate. You've got a variable degree of slurring. Axis is normal. There's no concordance. There's no real evidence of VA dissociation. So what do you think is going on? Absolutely right. It's an accessory pathway, pre-excited AFib. Next, please. So these were the options I was going to give you, but I think this is one. If you're doing a FCPS or an MD, this ECG comes every year in the TOEICs. It comes in the intermediate module, and it also comes in the final exam. So not this particular ECG, but this question comes up every year. And the best management is, in our setup, is DC cardioversion, although there are some antiarrhythmic options as well. Next, please. Next. Okay, so this patient comes in, 85-year-old gentleman, very, very sick. It's a broad, complex rhythm. I'm not sure what the exact heart rate is, but for argument's sake, we'll say it's 100, approaching tachycardia range. So let's, is there anything obvious that anyone can see here? Let's go through the options. Next slide, please. So you've got options. You've got SVT with aberrancy. You've got pre-excitation. You've got drug overdose. You've got electrolyte abnormality. And you've got ventricular tachycardia. So let's have a hands up. Does anybody think this is SVT with aberrancy? No? Okay. What about pre-excitation, like the last one? Delta waves? No? Okay. Anyone think this could be due to a drug overdose? Okay, one person. Fair enough. It could be. Anyone think this is a particular electrolyte abnormality? That's interesting. What electrolyte abnormality? Well done. Excellent. VT, it seems a bit difficult. There's no pathognomonic features. There's an atypicality to it, but yeah, I mean, the T waves are massive, aren't they? They're symmetrical and they're massive. There are wide QRS complexes, and you can't really see any P waves. So you read the script, you usually read ECG one way, but in hyperkalemia, you read right to left. So you notice the T waves first, and then you've got QRS, and you've got atrial standstill. There's no real clear atrial activity that I can see. Fine, well done. But that's a spot diagnosis. Next. Next. Okay, so next slide, please. Okay, so these are your options. So let's go through it using, this is a wide complex tachycardia. Let's use the ABCD approach. Axis. Is the axis normal or is it deviated? Yes, look at AVR. Look at AVR, the top of the screen. Yeah, you've got broad. So, I mean, for me, that's enough information. But let's go through the rest of the criteria. Is it really, really broad or kind of borderline? Yeah, you can say some of the complexes look quite broad. Okay, so is there concordance? No. V1, V2 are positive, V4, V5, V6 are negative, so concordance isn't there. But remember, you only need one of these criteria to diagnose VT. You've already diagnosed VT on the basis of the axis and the breadth of the complexes. All right, VA dissociation. Now, I suggest you look down here at the rhythm strip, and these are spikes, negative spikes, but there's a dome in between each spike. This is a dome. This is a dome, this is a dome. Are there differences in the morphology of these domes? Yeah. Yes. I would argue that this, or let's go further along. This is probably a P wave somewhere there on top of a T, and it's not there, but you've got another P wave there. So when you've got differences in the smooth parts between the spikes, that could be suggestive of VA dissociation. So there's an A present in some of them, but not in the others. There's no capture beats or fusion beats. So in the ABCDE algorithm, A, yes. Remember, you only need one to diagnose VT. A is there. B, maybe, plus, minus. C, no. D, in terms of dissociation, yes. We've got VA dissociation, pathognomonic of VT. The last one is kind of early part of QRS. Not sure, you know, but yeah. Next. Okay, what's going on here? It should be rather obvious. It's a spot diagnosis, but it is broad complexes. Yeah, it's a pace rhythm. It's a pace rhythm, but you'll be amazed the number of times people come to me with this ECG and say it's VT. Next, please. Next. And next. Okay, so this is another broad complex tachycardia. Patient is stable hemodynamically. Now let's go through our algorithm. Is the axis extreme northwest axis or not? No, because lead 1 is positive, lead AVF is positive, lead AVR is negative, so axis seems to be normal. Breadth, is it really broad, more than 200 milliseconds? No. Concordance, are all of the chest leads positive or are they all negative? No. D for dissociation. Is there any evidence, are there any capture beats or fusion beats? No. Is there any evidence of VA dissociation? Are the smooth parts, are the round parts between the spikes, the domes, are they different in any way? No. Okay, look at the intrinsicoid deflection. Is it a really, really slurry or is it a bit sharp? Yeah, I think you can say it's sharp. So A, B, C, D, E, we've looked at all of them. None of them are present. And let's look at the options. So anyone for SVT with aberrancy? Okay, good. Anyone for pre-excitation? Anyone for pacing? Is there a pacemaker? Anyone for electrolyte abnormality? Is there hyperkalemia going on here? Okay, anyone for ventricular tachycardia? Right, so the majority is right. It's SVT with aberrancy. So I hope that's helped you. I would say the best tip I can give you is if you're not sure, take a picture, look at every lead one by one, use the ultra-simple Brugada criteria if nothing else is coming to your mind. Look at limb lead 2 for the ultra-simple Brugada criteria, and look at the R wave peak time or the S wave peak time. If it's more than 50 milliseconds, then it's probably VT. Then use the ABCDE criteria. A for axis, B for broad complexes, more than 200 milliseconds, C for positive or negative concordance, D for VA dissociation, which includes capture beats and fusion beats, and E for the early part of the QRS, is it slurry or not. If you apply that and you use a bit of common sense and look at the patient's history, I don't think you're going to miss much. So I wish you the best of luck, everyone. Thank you very much.